Assalamu alaikum. Today's lecture is unloading of left ventricle and peripheral V ECMO story from real cases. And this lecture it's considered the second lecture of an LV unloading, but today we will speak in a practical way about the difference between two modalities, intra-aortic balloon pump and Impella in LV unloading. The first case is a 67 years old male, ischemic heart disease, diabetic hypertensive with severe aortic stenosis. The patient admitted with severe chest pain. Coronary angio was done, showing mitral vessel disease. The echo was done, showing ejection fraction, the ventricle ejection fraction 30 to 35%, with regional wall motion abnormality, mild to moderate mitral regurg, and severe aortic stenosis. The patient has emergency of pump. cabbage by 1, Lima 12 AD, was done due to porcine aorta, was planning to second session in cath lab for TAVI, changing the aortic valve. The patient admitted to ICU with high entropic support. Echo was done, showing a severe LV and RV dysfunction with persistent lactic acidosis and unstable hemodynamics that mandates insertion of ECMO. TAVI was done in the cath lab, and also the patient was sent to BCI in the cath lab. Transesophageal echo showing LV distension with the poor contractility of LV, smoky appearance present, but there is opening in aortic valve. Every beat has aortic valve opening. As patient had LV distension, intra-aortic balloon inserted, better hemodynamics, so we started to wean inotropes. Then the patient started to stabilize. Weaning of ECMO successfully moved on the third day. The aortic balloon was removed on the fourth day. Patient extubated on sixth day. Then on day 10, the patient was transferred to ward. X-ray after insertion of the ECMO and before insertion of intra-aortic balloon pump. There is a white lung or congestion, lung congestion, and if correlated with the echo, which is showing LTE, showing LV distension, and after inserting the intra-aortic balloon pump, the lung started to improve, and the white lung started to decrease, and the LV distension improved. This echo at the stage of removing the ECMO before decannulation markedly improved in left ventricular function. The second case is 51 years old female, rheumatic heart disease, mitral stenosis, history of chronic atrial fibrillation. She has mitral valve replacement, tissue valve, size 27, through transatrial approach, and the thrombus removed from left atrial appendage and left atrial appendage closure. The patient has cross-clamped 2 hours and was transferred to the hospital. With ECMO, high entropic support, echo showed LV dysfunction and ejection fraction at 10%. The patient was sent to cath lab for coronary angio, which showed normal coronaries, and lactate was increasing. This echo was done, showing severely distended LV with poor contractility. The decision was taken to insert Impella CP with flow 33.5 liter per minute, and after inserting Impella, we go gradually decrease ECMO to 1.7 liter per minute, and the entropic dose continue to decrease till we get off entropic support. This echo showing aortic valve opening before it wasn't opening before inserting Impella, and this is the Impella in the echo appeared. Impella passed the aortic valve through trans-aortic valve. It's just 2 lines to this is the way it's appearing in the echo. It take the blood from the LV and pushing the blood to aorta, so it respects the antegrade flow of the blood in the aorta. and help to unload LV. Report of TE showing there is significant improvement in global LV contractility and systolic function, and also RV contractility compared to the previous study. So ECMO weaning was starting, and we can move to ECMO on day 3. This is the echo showing at time of weaning how the LV improved, good contractility, and the RV is not well visualized in this view. The flow of Impella reduced to 2.5 liters per minute, and transthoracic echo, which was done on day 5 post-op, showing that left ventricle is normal in size and left ventricle ejection fraction 50%. The right ventricle is normal size, and the right ventricular systolic function is mildly reduced, TAPC 1.45 centimeter. Apical fourth chamber showing improvement in left ventricle and right ventricle contractility. On day 7, the patient Impella is removed, weaning from inotropic support, and the patient extubated on day 7 and transferred to the ward on day 10 and charged to home on day 14. So now we are talking about need to discuss unloading of left ventricle in VA ECMO. There is complete lecture for VA ECMO unloading in ECMO series, but I will try to concise through some important tips in this lecture. First, what is the hemodynamic target from ECMO? ECMO drain the right atrium and return back, peripheral V ECMO return back to the aorta. So at that time, ECMO will decrease RV unloading, compressing the RV and lead to decrease LV unloading. But when draining into aorta, it will increase the left ventricle afterload, lead to LV distension. So that will lead to RV decompression and LV distension. That's why it's very important to monitor daily echo for LV distension, which will affect to pulmonary congestion and lead to hypoxia. Oh, this is a cause of hypoxia on LV ECMO if the patient has LV distension. About flow optimization and management and preventing LV distension during ECMO, I recommend this paper for unloading and venting during VA. Indicator for LV unloading. First, no aortic valve opening, increased left ventricle end diastolic diameter, presence of pulmonary edema, which as a result of LV distension, rising pulmonary pressure, rising pulmonary capillary wedge pressure, which is reflected back from LV, and increased left ventricle and left atrial pressures, presence of low pulse pressure. This is all of these indicating that we need LV unloading. Important tip for all venting is unloading, but not all unloading is venting. This is an important tip to differentiate between venting and unloading. So we can use unloading early to prevent distension and add venting if LV dilatation or pulmonary edema develops. Let us define unloading. It's a reduction in LV pressure and volume work, decrease LV afterload and or preload. The goal to decrease myocardial oxygen demand, improving recovery and prevent LV distension. It may be achieved pharmacological or mechanical. Venting, it's direct removing of blood from the left ventricle chamber or left atrium. It's used to compress the left ventricle and also reduction of pulmonary congestion. It requires a mechanical pathway for drainage. Vent catheter, Impella, LA or LV cannula. Modality for LV unloading, non-invasive maneuver, invasive maneuver, and combination therapy. What are non-invasive maneuver? Avoiding high ECMO flow, using the lowest flow, which provides you with normal lactate, and good urine output, and the patient is conscious. Increase PEEP, which enhancing the lung function and oxygenation, limiting inotropic support, minimizing cardiac stress, and the potential side effect, limit vasodilatation, maintaining stable blood pressure, and reduce fluid leakage. Invasive modality like intra-aortic balloon pump, Impella, transaortic left ventricle catheter, left ventricle apical banding. In the previous two cases, we choose one case intra-aortic balloon pump and the second case Impella. So based on what we choose that. Let us compare between both of them. Intra-aortic balloon pump will provide counter pulsation and make the ECMO flow as a pulsatile flow so as to also will decrease left ventricle afterload. Impella directly unloaded LV by providing continuous flow support. Lead tension equals 4 things. First, LV tension due to peripheral VA ECMO, high flow, white lung or pulmonary edema, and low pulse pressure, no aortic opening. So these are things we will think about LV tension. Now we are going for unloading with pharmacological unloading. Why we choose intra-aortic balloon pump or Impella? Intra-aortic balloon pump plus VA ECMO. It will decrease the afterload, augmenting the diastolic perfusion. It can use for unloading in mild to moderate cases of LV distension. It will relieve, causing some effect to relieve pulmonary congestion. Also decrease myocardial demand. Moderate improvement in hemodynamics. It's less invasive, lower complication, but it can only use in mild to moderate LV distension and borderline hemodynamics. But in Impella or using Expella, it's actively pump the blood from the left ventricle to aorta, so true unloading, strong and direct unloading, it's more effective, significant reduction in myocardial oxygen demand, greater improvement in cardiac output, more invasive as it will pass through the valve, higher bleeding complication, hemolysis and vascular, severe left ventricle overload, resistant pulmonary congestion, pulmonary edema, no aortic valve opening. Another important part to avoid Impella is not all patients on VA ECMO are candidates for Impella to assess LV unloading. There is severe aortic insufficiency in patient who has significant aortic stenosis, significant mitral regurg, may not adequately to unload LV ventricle in these cases. This study is an international cohort multi-center study showed that left ventricle unloading is associated with lower mortality in patients with cardiogenic shock treated with ECMO. The study concluded that in this international study, the left ventricle unloading with lower mortality in patients with cardiogenic shock treated with VA ECMO, despite higher complication rates. These findings support the use of LV ventricular unloading in patients with cardiogenic shock undergoing VA ECMO and need another validation, and the ideal to confirm this study is using a randomized controlled trial. Our key message for this lecture: if the left ventricle is struggling but still ejecting, use intra-aortic balloon pump. If the LV distended and not ejecting, use Impella. This is references of this lecture which I use it. Thanks, thank you, and I am waiting for the comments and questions below in the comment.